Good. Good afternoon, everybody, or morning for those that are in a different part of the country. So I am going to do a brief presentation on HIV and hepatitis B co-infection and focus in 15 minutes on two areas. One is talking about epidemiology screening, and then spend more time talking about hepatitis B treatment in people who are co-infected. So to start with the epidemiology, and this is known to most people, but just sort of looking at this as a Venn diagram, this is actually old data, but the combination is really not any different. So if we look worldwide at the approximately 400 million or so people with chronic hepatitis B and those 40 million or so with HIV, there is this overlap of 3 to 4 million co-infected individuals throughout the world. And looking in the United States and Western Europe with a co-infection prevalence between 6 and 10% or so of hepatitis B co-infection in people who are infected with HIV. Then the table just sort of summarizes some facts about both viruses, which I'm not going to go through in detail, except to say that both viruses integrate into the genome, one, HIV being an RNA virus and hepatitis B being a DNA virus, but there are mutations that result in both situations in resistance to certain agents. And so when we think about medications that are effective against both viruses, we have to think about the potential consequences of resistance to those medications for both HIV and hepatitis B. So in terms of the clinical course, so this just, and people are familiar with this, so I'm not going to spend a lot of time on, this is just what happens in people with hepatitis B so that I can set up how HIV affects this disease progression. So people get acutely infected with hepatitis B, then a significant percentage, depending on whether or not you're infected perinatally or as an older child or as an adult, will progress to chronic infection. And then the complications that occur in those who are chronically infected are ones you're familiar with: liver cancer, hepatocellular carcinoma, cirrhosis, and decompensated liver disease, which can then progress to either requiring liver transplantation or to have significant mortality. We know from studies that this is from a now relatively old study that associated hepatitis B DNA, or the amount of virus in the blood, with an increased risk of hepatocellular cancer and cirrhosis. So this is in people who are mono-infected with hepatitis B, looking at the cumulative incidence of both hepatocellular cancer and cirrhosis related to the amount of hepatitis B virus. And so the higher the viral load, the greater the amount of hepatitis B, the higher the cumulative incidence of both hepatocellular cancer and cirrhosis. And so how does HIV impact those things? And it really impacts at multiple steps along the way. So there's a higher rate of chronicity of viral infection in people who are co-infected with HIV. And that risk increases the lower the CD4 count is at the time of HBV acquisition. So in people who are immunocompromised at the time that they acquire hepatitis B, they're more likely to progress to chronic hepatitis B infection, and then more likely to progress to liver disease. There are higher rates of hepatitis B replication, so viral loads will be higher. And so that's that relationship between progression of disease. There's a lower rate of spontaneous loss of either hepatitis B surface antigen or E antigen, as well as seroconversion. And then, therefore, because of all those things, higher mortality rates when compared to monoinfection of either virus. The ALT levels tend to be lower in people with chronic infection, mostly because of decreased ability to have inflammation in the liver, although that's changed as people are treated for their HIV earlier. Faster progression to cirrhosis, a higher incidence of lamivudine resistance, one of the drugs that was commonly used to treat, and an increased risk of hepatocellular cancer. Just showing graphically the increased risk of end-stage liver disease due to hepatitis B. Again, old data, but comparing people who are co-infected to those who are either HIV mono-infected or hepatitis B mono-infected, and those that are co-infected have a much higher rate of liver mortality compared to mono-infection, approximately 17-fold in this large cohort that has been studied since the 1980s. And then one of the questions then is, has this changed over time with the introduction of better anti-HIV therapy? And you can see here, breaking this down over time, that liver complications, end-stage liver disease, and hepatocellular cancer have really not changed that much in the more recent antiretroviral era. So this representing a time where we had effective anti-HIV therapy compared to when we didn't. And you can see these complication rates are relatively similar. So what about diagnosis? And just very, very briefly, because we've talked about this before with this group, but just using hepatitis B surface antigen, antibody, and core antibody. The one thing that's different in co-infected individuals is the presence of isolated hepatitis B core antibody. The rate of isolated core antibody can be as high as 12 to 20% in HIV infected individuals, and even higher in those who have hepatitis C as well. And this could represent a variety of things, including being in a window period of acute hepatitis B infection, but maybe more importantly, waning immunity to hepatitis B, or signifying occult hep B viremia. So these people who are core antibody positive have the genetic machinery to make hepatitis B within their liver. And what that means is that they're at risk for reactivation when there is intense immunosuppression. And that could be with a really low CD4 count, or if people need to be on immunosuppressive therapy for whatever reason. And then the other point just to make, which people are familiar with, but just to emphasize, is that immunization works in people who are co-infected. And so if people do not have surface antigen or surface antibody or core antibody, they should be immunized. And then to talk about treatment and where we are. So these are most of the agents, excluding interferon. So the oral hepatitis B active antiviral agents, with the ones that are bolded being the ones that are most commonly used. And so we'll talk about lamivudine or epivir, but just if you contrast these two, so lamivudine and emtricitabine, they have moderate potency against hepatitis B with relatively low barriers to hepatitis B resistance. But they do have activity against HIV, and there is resistance that can be reported against these drugs in people with HIV. The other drugs that are active against both viruses and are used against both are tenofovir and then the newer version of tenofovir called tenofovir alafenamide, or TAF. Both are high potent drugs against hepatitis B with a higher barrier to resistance. And as I mentioned, they both have HIV activity, but there can be resistance to HIV with both of these drugs, although they're less common than with lamivudine or emtricitabine. Both, and particularly emtricitabine, is used in combination for HIV because they are combined in single pills, tenofovir and emtricitabine in Truvada, and tenofovir alafenamide and emtricitabine in Descovy. So when do we start antiretroviral therapy in people who are co-infected, and what regimen do we use? And it's simple enough to just say antiretroviral therapy is recommended for all HIV-infected individuals, regardless of CD4 count. And the reason for that is it reduces morbidity and mortality associated with HIV infection. So really, the answer to this question is the same. We use it in everybody. And we predominantly use the combinations that I mentioned, tenofovir and emtricitabine, or tenofovir alafenamide and emtricitabine, as the nucleoside or tied backbone in people with HIV. Entecavir can be used, but it's generally used to treat the hepatitis B part, but it's generally used if there is some reason to not use tenofovir or tenofovir alafenamide. And if you are going to use entecavir in an HIV-infected individual, they should be HIV suppressed, because entecavir does have some anti-HIV activity, but not enough to induce HIV suppression. And so what that means is if you use entecavir alone in a co-infected person, they're going to develop, the HIV is going to develop resistance, which can translate to resistance to other drugs. The other point to make about therapy here is not to stop hepatitis B active therapy in people who are co-infected if you're changing their HIV regimen. Just because tenofovir alafenamide is a newer drug, important to mention that it has been compared to tenofovir and been studied in people who are co-infected. Small study, but resulting in HIV suppression and hepatitis B suppression below limit of detection at week 48, with normalization of ALT levels. And the advantage to tenofovir alafenamide is not as much an effect on renal function and not as much an effect on bone turnover as is seen with tenofovir. And those drugs, either tenofovir or tenofovir alafenamide, over time result in regression of fibrosis. And this is a study in mono-infected individuals that looked at regression of cirrhosis as measured by ESHOC score over a 5-year treatment period, and showed a significant decline in the amount of fibrosis in people treated with tenofovir. As I mentioned, resistance can occur. This compares mono to co-infected individuals who are on lamivudine for a long time, and when they're on lamivudine as a single agent, resistance occurs in the vast majority of people who are co-infected with HIV and hepatitis B. And so this would argue against using lamivudine as a single agent. But what happens when you get lamivudine resistance and then you try to add tenofovir? In general, you will get virologic response with the addition of tenofovir, although small percentage of people will not achieve virologic response. In this study, about 10%, with another 5% who had breakthrough of virus. So lamivudine resistance can affect the response to other agents, particularly tenofovir. In this small study, the addition of another drug, traverine, did result in undetectable virus in a small number of people. So how do you monitor people on therapy? Recommendations are viral load every 3 months until undetectable, then every 6 months, with e-antigen monitoring every 6 to 12 months if people are e-antigen positive, monitoring liver enzymes 6 and 12 weeks after initiation, and then every 3 to 6 months, and we'll talk about why in 1 second, monitoring electrolytes and creatinine, really to monitor toxicity of drug, and particularly if on tenofovir, monitoring for evidence of bone disease as well as protein in the urine. And then we define response similarly as in hepatitis B mono-infected individuals. So there's nothing unique about this in co-infected individuals. And then I just want to bring this up because it applies to the case. So if we look at this individual scenario here in someone started on tenofovir with a viral load that continued to rise, developed mutations probably to the FTC part, and then added entecavir and saw a drop in viral load. But that's not the only thing that happens. The other thing that happens to co-infected people is they get immune restoration. And that immune restoration is also important in getting a viral load response. So we can't always say it's just drug. The immune system has a role there. And it's important to realize that it takes longer to drop your viral load in people who are co-infected than in people who are mono-infected. And there are risks for that. And the risks for delayed response are previous 3TC, a higher viral load level greater than 10,000, and a lower CD4 count at nadir. So those are people who will take longer to suppress completely their hepatitis B viral load when they are on an effective agent like tenofovir. And you can see the comparison of those who are on 3TC versus those who had not seen that. So what do you do in these people? And guidelines both from the AASLD and HHS from mono-infection suggest continuing drugs with really no threshold for a regimen change, with AASLD suggesting 96 weeks and considering the addition of entecavir with the development of undetectable hepatitis B after entecavir intensification in between 1/3 and 40% of individuals. This is a small number of patients, but this is what can be done in people who are not suppressed. And the last thing just to mention is that the other thing we see in co-infected individuals is ALT flaring after starting antiretroviral therapy, which could also be hepatitis B therapy. And this is related to an immune restoration phenomenon. As the immune system comes back, there's more inflammation in the liver, and you can see increases in liver enzymes. That generally occurs 6 to 12 weeks after starting antiretroviral therapy. But it could also be due to, if you stop hepatitis B therapy, if there is drug resistance or if there is drug-induced hepatotoxicity, and not forgetting that there can be other infectious causes of hepatitis. And the predictors of who was going to flare were people who had a higher hepatitis B viral load, a lower CD4 count, and higher liver enzymes prior to beginning antiretroviral therapy. So these are things just to watch out for in co-infected individuals when you're starting therapy. What do you do for this case? In many cases, the ALT flare will resolve even by continuing medication. So it's not a definite indication to stop therapy. You should assess for other causes of hepatitis, look for these measures to see what hepatitis B viral load is doing. Very rarely, biopsy may be helpful in distinguishing drug toxicity from other causes. Get your friendly hepatologist involved early, and only think about stopping antiretroviral therapy if there are symptoms of hypersensitivity like fever, adenopathy, or rash, or there is symptomatic hepatitis or rises in enzyme levels greater than 10 times the upper limit of normal. So in summary, co-infection with hepatitis B occurs in people with HIV. HIV accelerates the progression of hepatitis B virus infection. Dual hepatitis B active antiretroviral therapy should be used to minimize resistance. Try to avoid stopping therapy for hepatitis B when you're changing HIV therapy. This is controversial about immunizing patients with an isolated hepatitis B core, and many people would say this hepatitis B core is actually indicative more of active disease within the liver. And remember, in people who've developed cirrhosis, to not forget cirrhosis counseling and hepatitis C, HCC surveillance.
Thank you so much. Just want to open it up for any questions on the didactic presentations or comments.
Yeah, I did. I actually had a quick question. For patients who are co-infected with HIV and hepatitis B, and they are under treatment, so their hepatitis B is undetectable, does that speed up or slow down, or not speed up, but does that eliminate advanced damage to their liver if they are undetectable for Hep B?
So great question. And I would say it doesn't eliminate it, but it decreases the likelihood of developing, particularly developing HCC. There's a really clear association between hepatitis B viral load and HCC, and it really does bring up why it is important to try to get these people completely virologically suppressed. But I would say if it wouldn't abrogate the need to still do HCC screening,
Sure.
unless they've really seroconverted and lose their surface antigen.
All right, thank you.
Sure.
Any other questions? All right, well, we'll move on to our case. I just want to note that if you have any questions or think of them as we're talking through the case,